Let me just start by saying thank you so much to anyone who's taking the time to watch my presentation. This presentation will take approximately 1 hour. My motivation for doing this presentation stemmed from a period of about 3 to 4 years ago when I had the opportunity to treat some arthroscopic labral hip repairs. I followed the patient's protocols to the T, and the patients did very well. However, it became evident to me that I did not have the experience, the knowledge, or the confidence to be a very clinically intuitive hip therapist. I wanted to create a resource of foundational knowledge that could be immediately applied to our non-operative patients. And furthermore, I think this presentation could be and maybe should be applied to our arthroscopic patients also. That, however, needs to be a separate presentation, and we will certainly talk about that. So in terms of objectives, I simply want to focus on the information that will be the most clinically applicable by relying heavily on the research and demonstrating some ways in which we can implement that information with our current group of patients. I would like to take a second to show an anecdotal video from a company called Boston Dynamics. Their department was involved in a project to develop a robot that could walk over very unstable surfaces. As you can see, he utilizes his entire kinematic body frame to balance himself like an acrobat on the tightrope. I spoke to a researcher with the company who said the hardest part of the project was developing a robotic hip that had the mobility and the stability to withstand a converging confluence of eccentric force vectors. I wanted to include this video because it simply gave me a greater appreciation for how much work that we try to recruit from the hip joint when we are walking, as I mentioned, on unstable surfaces. So for the first decade of my career as a therapist, I found that I really did not possess a very positive attitude towards the hip joint in general. As someone who really enjoys manual therapy, it felt like the hip was kind of the Bermuda Triangle of manual techniques. In other words, I really couldn't see it, and I really couldn't feel it as well as the ankle, the shoulder, or the knee. I was also very intimidated by the three-dimensionality of the joint as well. What I've learned is that we really need to embrace the hip, because in many ways it is the alpha and the omega in just about every conceivable athletic movement that our patients engage in. The hip drives the upper extremities, and it drives the lower extremities as well. There have been hundreds of studies that have demonstrated the tremendous biomechanical influence that the hip exerts in the world of sports, and I've included a few of those studies right here. Speaking of biomechanics, the most important job of the hip musculature is to decelerate and control motion. The external rotators decelerate internal rotation, and the internal rotators obviously decelerate external rotation. I would like to start with a 2007 article because it really summarizes where my knowledge of the hip used to be as a therapist. The author, Dr. Pollard, wrote that compared with male athletes, female athletes demonstrate a significantly greater hip internal rotation and decreased hip flexion. Secondly, female athletes demonstrate a greater adduction and lesser extension moments than their male counterparts. As we will see, there is a lot more to the story. But first, let's take a look at pathology. Marcy Harris Hayes published a 2014 article in the Journal of Sports and Orthopedic Physical Therapy that stated that repetitive hip internal rotation may contribute to increased compressive forces in the anterior hip joint, leading to mechanical impingement and subsequent injury to the acetabular labrum and articular cartilage. Repetitive external rotation may result in an accumulation of tensile stresses to the capsulo-ligamentous structures in the acetabular labrum, leading to injury and potential micro-instability of the hip. Excessive hip adduction with gait, especially distance running, has also been implicated in chronic hip joint discomfort. There is an increasing awareness and acknowledgement of an association between labral pathology and sports hernias. Munagato wrote in 2015 that a variable association of 12 to 94% has been seen with sports hernias and femoroacetabular impingement. It is proposed that an increased rotational stress on the symphysis pubis and the surrounding structures from femoroacetabular impingement leads to weakness of the posterior inguinal wall. So when we see a patient present with a very acute hip, swollen, tender, stiff, weak, uncomfortable, where do we begin with those patients? Let's start with the hip capsule. James Cyriax first wrote in 1982 that the capsular pattern of the hip is flexion greater than internal rotation greater than abduction. But David McGee, in his orthopedic assessment text, wrote as recently as 2014 that the capsular pattern of the hip is flexion greater than abduction greater than internal rotation. Other sources have even listed external rotation instead of internal rotation. So why the discrepancy regarding the capsular pattern of the hip? Let's take a look. In 2003, an author by the name of Claspo wrote that there is unreliable data demonstrating any consistent capsular pattern in hips with extreme osteoarthritis. However, in 2008, an author by the name of Sutlive wrote that passive hip internal rotation less than 25 degrees and pain with extension and abduction can help predict hip osteoarthritis. Finally, Dr. Ryman in 2013 wrote that restriction of hip flexion, internal rotation, and adduction is a defining characteristic with femoroacetabular impingement. So it appears that the hip joint can present differently based on the different pathologies that can occur with these patients. The bottom line is that we need to find where these patients are tight, we need to move those patients, mobilize them, and stretch them. Let's talk about reflexive inhibition for a second. We as clinicians do such a great job of assessing edema in the knee and measuring it, evaluating the resulting atrophy in the VMO, and utilizing re-education to address it. Why don't we do that for the hip joint? Probably because, once again, we can't see it or feel it very well. An author by the name of Ward wrote a terrific article in 2010 entitled The Architectural Design of the Gluteus Medius Muscle Group. He wrote, and I quote, "The gluteus medius muscle produces an exceptional amount of force given its size. The gluteus medius muscle is designed for stability and loses some strength potency when stretched three-dimensionally." A doctor by the name of Freeman in 2013 published an article entitled Arthrogenic Neuromuscular Inhibition, a Foundational Investigation of Existence in the Hip Joint. He wrote, "The findings of my study provide substantial support for arthrogenic inhibition following hip intra-articular fluid installation during functional tasks, including pelvic bridges and active hip extension." Finally, in 2014, an author by the name of Michael Wahoff, who is a physical therapist out of Vail, Colorado, who has produced a tremendous amount of hip research, wrote that he recommends a circumferential measurement from the greater to the lesser trochanter, parallel to the inguinal ligament. A 1 centimeter or greater difference is deemed to be significant. So can the hip joint form adhesions in the same way that we see with our shoulders and our knee patients? Of course it can. Dr. Willimon, who trained with the group in Vail, Colorado, wrote in 2014 that intra-articular adhesions are a significant cause of postoperative pain and failure. The following risk factors were identified: under the age of 30, a modified Harris hip score under 50, no microfracture, and rehab without circumduction. So let's go ahead and take a look at joint mobilizations of the hip. I recently changed the way I do a few of these after a recent lab session with Mark Christel, who is a terrific manual therapist. Here you can see a posterior hip mobilization whereby I am moving through rotation in an effort to find the point of greatest posterior restriction. Once I find that spot, I simply apply a posteriorly directed force through the long axis of the femur. Here is a simple long axis distraction inhibitory technique that should occur at about 30 degrees of flexion and slight abduction. I am trying to find the point of least resistance, and once I do, I can apply a low amplitude, high velocity thrust in an inferior direction. Now, for the anterior mobilization, it's important to rest the patient's leg in a little bit of rotation, and my force needs to be in an anterior and slightly superior direction. Once again, I can work around the area in an attempt to find the greater restrictions. Okay, here you can see the always tricky two-person caudal glide that should be applied in an inferior and slightly anterior direction as well. The second person applies a very mild amount of distraction through the horizontally positioned leg. The lateral hip glide has a bit of a mulligan feel to it, as we are trying to direct a lateral force through the adductor tissues with the belt, while simultaneously internally rotating the hip. Patients seem to love this technique, but it's important to remember that you may only generate a very small amount of internal rotation with some of our patients, especially those patients that may have some osteoarthritis of the hip. Mark was nice enough to show us the stretch that he follows this mobilization up with. You can see this patient trying to internally rotate his left hip while maintaining his right lower leg position against the true stretch. You can see as I pan over that the right leg cannot compensate when the foot is firmly abutted against the side of the true stretch. Hip circumduction is critical for our postoperative and even stiffer non-operative patients to regain their range of motion. Dr. Edelstein in 2012 wrote an article in the Current Review of Musculoskeletal Medicine stating that passive circumduction can be described as the pendulum exercise of the hip. Passive circumduction at 15 degrees, 30 degrees, and 70 degrees of hip flexion and slight abduction has been shown to be very effective. Neurophysiological benefits that include joint inhibition and reduction of potential capsular tensioning have been definitively demonstrated through the research that they have conducted. Here you can see the 30-degree circumduction being performed in a similar position to the long axis distraction, as the clinician leans in a posterior direction while moving the hip through a circular direction within the joint socket. This technique should feel very non-aggressive to the patient, and you are waiting to feel some inhibition within the joint and the surrounding tissues. Here you can see the 70-degree version with the patient's leg resting right on my shoulder. Once again, a circular motion of the lower extremity should be performed at a very comfortable pace for the patient. You can also add a rotational flavor at this angle, and the patients really enjoy this technique. If the patient had a labral repair, it would be very important to remember that they would be restricted for about 6 weeks with external rotation and extension. You can see this technique has a little bit of a McMurray's feel, but it is very important that the foot stays in a neutral position. Michael Wahoff has written extensively about the importance of prone positioning. He wrote in 2011 that he recommends multiple sessions per day of prone lying for about 45 to 60 minutes to reduce the possibility of flexion contractures in those patients that have had labral hip repairs. In 2014, he wrote an article in the International Journal of Sports and Physical Therapy that stated that the anterior hip benefits from allowing the iliopsoas to lengthen in a relaxed manner, which would obviously be based on the concept of low load, long duration stretching. A common issue with acute hip patients is their propensity for developing hip flexor irritation. Way back in 1970, they discovered that the adductor longus acts as a hip flexor and an abductor, and conversely, the adductor magnus acts as a hip extensor. Furthermore, Edelstein in 2012 wrote that soft tissue massage is highly encouraged for these patients. After surgery, the psoas is often inhibited and the adductor demonstrates increased muscle tone. The tensor fascia lata and the rectus femoris will try to compensate, and they often become irritated. In 2014, Mr. Wahoff wrote that sufficient iliopsoas activation is just as important with normal gait as gluteal activity. Furthermore, flexion straight leg raises are discouraged in favor of exercises like the Shirley-Sarman abdominal progression and the McGill curl-up progression. John DeWitt, in a 2010 Ohio State labral hip repair presentation, wrote that an iliopsoas progression could be marching to start with, moving to walkouts, then heel slides, and finishing with heel slides with straight leg raises. This young lady is performing a McGill curl-up with the injured lower extremity flexed. You can see she overactivates her upper trapezius and the suboccipitals initially, but she then reactivates her lower abdominals and utilizes her scapular musculature to perform the exercise more proficiently. So the second step would be to elevate the contralateral lower extremity with the ipsilateral upper extremity while maintaining good abdominal bracing. The third and final progression involves adding the lower abdominal crunch back in as well. Okay, let's take a look at another conservative hip flexor progression. The first video involves the tabletop position on the Swiss ball with resisted hip flexion and extension. Very, very simple to start with. So the second step would be to remove the Swiss ball and replicate the same exact progression. So the third step involves a bridge on the ball with resisted flexion and extension once again. I have even added a fourth step with some of my higher level patients, whereby the patient places the ball under only one leg while maintaining a 90-90 open chain position with the other side. Most clients will find that endeavor to be sufficiently challenging. Okay, the hip can be very deceiving to those of us who rely on single plane manual muscle testing that we learned in physical therapy school or athletic training school. The true weakness of the hip can oftentimes only be seen in a multiplanar, three-dimensional, closed-chain environment. So, it's important that we think about this three-dimensionally. Dr. Bowling, in 2009, in the Journal of Athletic Training, wrote that athletes with patellofemoral syndrome were 26% weaker with abduction and 30% weaker with external rotation, 52% weaker with hip extension. Furthermore, eccentric weakness is often 3 times more than concentric weakness, especially relative to rotational strength. Patients with a history of groin discomfort demonstrate loss of the feed-forward mechanism of the transverse abdominis and a change in muscle firing patterns of the gluteals versus the hamstrings. This has been well documented. It's important to know how to activate the gluteals while avoiding TFL participation. Very common mistake that we allow our patients to engage in. Lastly, joint compressive forces are almost 250% with performance of a side-lying hip abduction while wearing a 5-kilogram weight. That is equivalent, believe it or not, to a one-legged squat. Care must be taken to re-educate the firing pattern before initiating any dynamic activity. That may be accomplished by initially having the patient perform isometric techniques, much like we have our post-op shoulder rotator cuff patients utilize shoulder isometrics, with their initial rehab sessions. The second step for the hip patients would be to have the patient lie in a prone position and re-educate the transversus firing initially, then the glutes secondly, followed by a small hip extension range of motion exercise. That was noted by Edelstein in a 2012 article. Secondly, the sideline clamshell progression has become an established expectation, also known as the sideline gluteal progression. This is a four-step progression with emphasis on pelvic control. This was noted in a very important landmark hip article in 2011 by an author by the name of Boren. Please refer to their charts for consideration of gluteal strength interventions. An author by the name of Bagla in 2005 found the following progression of least to greatest voluntary gluteal medius effort. Supine abduction, then ipsilateral non-weight-bearing standing abduction, then side-lying abductions, then opposite hip abductions in the weight-bearing position, then flexed weight-bearing with opposite hip abduction, and finally pelvic drop exercises. Macbeth, in a very important 2012 article entitled Hip Muscle Activity During 3 Side-Lying Hip Exercises in Runners, wrote that side-lying hip abduction should be performed in internal rotation at no greater than 35 degrees of actual abduction. Secondly, abduction with external rotation mostly strengthens the TFL. The external rotation clamshell mostly strengthens the hip flexor group. Boren, once again in the 2011 article, wrote that in order to maximally challenge a patient's gluteus maximus and medius, they recommend a front plank with hip extension, a single leg squat, and a side plank with abduction. The authors then provided a ranked list of almost 30 gluteus medius exercises listed from least to most difficult. This was gained through EMG testing. The name of the article, for anyone that's interested, is entitled Electromyographic Analysis of Gluteus Medius and Gluteus Maximus During a Rehabilitation Exercise. An author wrote an article in 2011 entitled Sex Differences in Proximal Control of the Knee Joint. They stated, and I quote, female athletes show greater lateral trunk displacement, altered trunk and hip flexion angles, greater ranges of trunk motion, and increased hip adduction and internal rotation. Furthermore, there's increasing evidence that indicates that lumbopelvic control is the primary impactor on knee valgus collapse. Dwyer, in 2011, wrote an article entitled Comparison of Lower Extremity Kinematics and Hip Muscle Activation During Rehabilitation Tasks Between Sexes. He wrote, and I quote, sex differences in lower extremity kinematics have been reported during landing and cutting. However, less is known about the differences in movement patterns in common lower extremity exercises. Secondly, participants performed single-leg squats, lunges, and step-ups and overs. The mean amplitude outputs were higher for the gluteus maximus and the rectus femoris in female participants. However, no differences in gluteal medius activity between the sexes was noted, which supports findings of articles by Zeller and an important study by Yori-Thigis as well in 2007. Speaking of Yori-Thigis, his 2007 article was entitled Relationship Between Hip Strength and Frontal Plane Posture of the Knee During a Forward Lunge. In this study, no relationship could be established between hip muscle strength and a frontal plane movement of the knee during a forward lunge. This does suggest that there are other factors, such as proprioception and core stability, that might be more important in controlling knee movement with this activity. So, a consensus has emerged amongst researchers who believe that, in many cases, the gluteus medius strength is comparable between athletic females and males. However, the rectus femoris and the gluteus maximus muscle groups are deficient in most females under comparison. Furthermore, the transverse abdominis and the lumbar extensors demonstrated the biggest gender differences. Proprioceptive training is the most effective therapeutic intervention to lessen a valgus knee angle, especially when incorporating two main factors: enough training variability to negate a learning effect. Secondly, minimizing the participants' visual capacities and eyesight capabilities. So we thought that we were ahead of the curve by having our young ladies with patellofemoral syndrome devote much of their rehab time to isolated gluteus medius table strengthening. The reality is that we need to devote some of that time to the other hip muscles, such as the rectus femoris and the gluteus maximus. Okay, here you will see the sideline gluteal progression that I spoke about. The first step is actually just to perform a sideline external rotation clamshell, which I did not include. The second step is shown here with an isolated lower leg movement through the upward internal rotation while focusing on minimal pelvic and lumbar movement. The third step involves abducting the hip into about 30 to 40 degrees, maintaining a stationary upper leg and dropping the lower leg through the rotational range. Once again, the torso needs to stay perpendicular to the table with minimal pelvic motion. A nicely controlled pace with a brief pause at the top of the motion. The fourth and final step involves also extending the hip approximately 20 degrees before replicating all of the actions from step number 3. Next, I would like to take a look at 3 quote-unquote higher level core techniques that are seen by many folks as terrific interventions for our patients. Then, I would like to discuss the common concern that I have for all 3 of these techniques. The prone hip tuck involves utilization of the lower abs, the trunk extensors, as well as the rectus and the gluteus maximus. He needs to avoid excessive lordosis in the starting position, as well as too much pace that allows for overcompensation of momentum. You can see some fairly good disassociation occurring right here. The single leg bridge on the Bosu ball needs to occur with minimal thrusting through the lumbar and thoracic spines. I asked this young man to focus on using his glutes to peel the hips up and down in a very methodical manner while maintaining good pelvic symmetry. The prone plank on the Bosu and the Dynadisc with a straight leg extension lift. Too much extension is occurring and too much pelvic asymmetry as a result. I then asked him to flatten his hands and focus on less hip extension to allow better pelvic control in positioning. You can see a more confident execution of the technique after the skewing. So, in summary, those 3 interventions culminate in a great workout for the patient with some nice isolated muscle activity and some nice lumbopelvic re-education. However, all 3 of these took place primarily, if not exclusively, in the sagittal plane. The research encourages us to try and incorporate as much multiplanar weight-bearing work as possible to attain the best bang for our buck with these patients. So let's take a look at some Gray Institute stability matrix work that Mike Slemons was so generous in mentoring us about. You can see an anterior reach with the injured leg staying planted firmly on the ground. She is cued to drive her hips in a posterior direction while minimizing the anterior translation of the tibia over the talus. Controlled pacing is so very important with this technique. Next, let's take a look at a posterior reach with the torso trying to achieve a horizontal position while using the gluteus maximus to reach as far posteriorly as possible. Good lower abdominal control is so very critical with this technique. Things start to get a little frightening as this young lady then has major issues with the lower extremity lateral reach. A major valgusing of the left hip occurs with deeper flexion. Had she been a real patient, I would have discontinued this exercise when it became obvious that she did not have the coordination or the control to finish this proficiently or safely. So let's see what a better version of this same technique looks like. This young man does a far better job of keeping the mid-patella centered over the second metatarsal with proper control through the starting position. So here we have contralateral rotation. She really struggles with the first several attempts, and then we remind her of keeping the center of gravity over the base of support and to focus on squeezing through the belly button. She then does a fairly nice job with her last 3 to 4 efforts. Practice makes perfect, and I promised her that I would include her last 3 to 4 proficiently executed efforts. Here you can see her gaining some confidence with a cross-body lower extremity reach. She utilizes her pelvic ligaments a little too much, but you can see that she has appropriate pacing and determination to finish the effort. So let's talk about adding some hip-specific exercises into the normal lower extremity routine of our other patients. The quadruped rock is similar to the pray and the child pose stretches, but it can be done at a more rapid pace with some end-range pulsing to increase posterior capsule mobility. The Faber slide can be used to increase external rotation by stretching the anterior capsule. The Gray Institute Mobility Matrix and the 3D edge of bed flexor and extensor progressions are great options also. Let's start with the 1/2 kneel position and a belt that provides some mobilization, a la the mulligan concept. You can see that she can drive this technique in multiple planes with various arm movements, and she can also vary the position of the down leg through internal and external rotation, all the while keeping a good pelvic neutral position. Here you can see the flexion progression with the injured leg starting in a fairly high degree of flexion before driving the arms through the matrices of options. You can see a combo option of simultaneous side bending and rotation to finish this workout. Now, if you wanted to add some unpredictability and some variability, you could add a ball toss also. My only request to this young man was to simply change his posterior leg position every 4 to 5 throws to allow different angles of rotation to occur at the hip joints. As you watch this video, you can see that he does indeed change his posterior leg position about every 4 to 5 ball tosses. If you wanted to make this technique a little more difficult, you could simply increase the amount of reaching that he has to do with the tosses, as well as increasing the height of the step. In terms of the flexor stretch, edge of bed progression, it was important to start with good anatomical plumb line position, with the pelvis tucked appropriately and good spinal alignment. She works through the sagittal plane to start with and concentrates on maintaining a nice, steady pace. Next, she rotates with a mental focus on avoiding right femoral adduction and, more importantly, left femoral abduction, keeping a nice vertical alignment of the knees beneath the hips. As you watch, you can see that she is indeed doing everything she can to avoid that left femoral abduction. Lastly, you can see some frontal plane side bending work that would benefit from probably having a 2 to a 4-inch block below the right lower extremity to allow her to avoid any pelvic shifting and to really help emphasize some nice spinal side bending. Okay, the next 3 techniques were most impressively presented by the Ohio State Rehab Department, and all 3 really do a very nice job of combining good capsule mobility with a simultaneous interaction of the core and the hip musculature. Here you can see the Spider-Man stretch with Alicia initially working to find a good balance point to rotate from. Starting in the push-up position, lunging and then working through the ipsilateral and contralateral spinal rotations, all the while maintaining good balance and hip control. The scorpion stretch begins in the prone position, and the patient focuses on maintaining good table contact with the shoulders and the thoracic spine, while elevating the movement pelvis just enough to allow an extension followed by a rotational moment across the table. This technique requires excellent hip and lumbar extension, mobility, and a nice interplay of lumbopelvic musculature. The infamous inchworm requires good capsular mobility to reach to the floor, good core control to walk out and back, as well as having really good hamstring and glute max control to finish the effort. Additional information and concepts. The Alter-G jog progression can begin at 6 weeks in some of the arthroscopic hip protocols. Furthermore, you want to quantify closed chain rotational abilities with 3D floor measurement mats. You will see a surprising amount of resistance from the anterior and the posterior hip tissues in some of these patients when your goniometric measurements on the table seem to be fairly symmetrical. Thirdly, always think 3-dimensionally with conventional rehab concepts. Squats, clam walks, lateral step downs, and the lunge matrices through neutral, internally rotated, and externally rotated positions. And finally, you may need to work from the kneeling to the 1/2 kneeling position when beginning eccentric progressions. Do not underestimate the level of eccentric weakness that you will see with many of these acute hip and postoperative patients. Okay, let's go back to the young lady that really struggled with the lateral reaches while we were working on the Gray Institute stability matrix. She struggled mightily in maintaining good anatomical position while she reached in a lateral direction. It might be a very wise idea for a patient like her to go ahead and put her in the kneeling position. You can do this on an unstable surface with the Bosu ball. Have her utilize a little upper extremity control by having her place her index finger on a stable surface, such as a table, and have her very slowly and carefully work through an abduction moment while maintaining good pelvic symmetry. You can see that she's far more proficient in this position than she was in the standing position. And I can say with confidence that she will benefit greatly through doing and performing multiple repetitions in this position. So once again, you will see a more finite analysis of hip restrictions and asymmetries in the standing position compared to table goniometry. The first video shows a simple static external rotation assessment with the heel held firmly against the ground. Moving forward, you can see that this young man can perform an internal rotation assessment that requires the contralateral foot to be moved posteriorly about 3 to 4 inches to allow the full rotational movement. If you wanted a larger kinematic analysis, you can do that by having the patient step posteriorly and finish with an ipsilateral trunk rotation. Through modern video technology, we can then extrapolate the step distance, the degree of hip rotation, and the degree of trunk rotation also. You could also compare some qualitative factors with a side-by-side analysis of the contralateral rotation. Okay, so the next step in this learning process, as I previously mentioned, is to apply some of these principles to our postoperative hip cases also. We could utilize Dr. Batier's postoperative hip protocol, and we could also go back and watch Scott Daniels' symposium presentation on the rehabilitation of arthroscopic hip procedures. Furthermore, the Ohio State Labral Repair Rehab Considerations presentation is very educational and informative. This can be accessed through the internet. Our very own Andrew Sweeney presented some of this information at a local OPTA conference in the greater Cincinnati area last year. It is very important that we utilize these concepts and utilize this information and apply this to our patients from our doctors in the marketplace in which we work.
What do you think having a 37-year-old?
We're on to Cincinnati. It's nothing about the past, nothing about the future. It's right now we're preparing for Cincinnati.
Okay, do you feel like the talent you have here is good enough?
We're getting ready for Cincinnati. We got to turn the
I did include a bibliography of the 36 references that I referred to during this presentation. If you are looking for a reference, this might be a good hip resource to start with. Once again, I would like to say thank you to anyone who took the time to listen to this presentation. If you have any thoughts or comments or questions, please feel free to email me at raltenburger@mercy.com. Once again, thank you so very much for your time.